The next presentation is on the Hillsborough County Health Care Plan of Hillsborough County, Florida. Patricia Bean, the Deputy County Administrator, will make the opening presentation, followed by Michael Cole, the Director of Innovations and Technology Program.
Good
Please
morning.
proceed.
We're very honored to have this opportunity this morning to present to you Hillsborough County's version of healthcare reform known as Hillsborough Healthcare. There were a variety of reasons why we got into this project. First of all, back in the 1980s, we saw the cost of providing indigent care to the citizens of our county escalating rapidly, and we recognized that if we didn't do something different than what we were doing at the time, that pretty soon the cost of that care was going to absorb the majority of our local ad valorem property taxes. So we knew we had to make a difference. Secondly, we had a public hospital that was in financial trouble. Discussions were occurring about privatization, and the community was not happy about that. We also had recognized for some time that we were really providing this care or paying for this care at the wrong end of the spectrum of care. We were paying for it at the back end when it was the most expensive. We let people get really ill, have to be hospitalized, and then we paid rather than focusing on primary care and early intervention. So the county became a catalyst to bring together a coalition of folks from all over our community. We had the local medical association involved. We had the local hospital council, the Chamber of Commerce. We had the school board. We had insurance representatives. We had members of the mental health community. We had the local medical school at our local university. We had the public health college and a variety of consumer organizations from the community and individual consumers who came together to help form this coalition with a real commitment to help us solve this problem. And that commitment is so great, in fact, that it has continued throughout the 3 years that we're now in operation. And we have a consumer or citizen advisory board that is chaired by Michael Cole, who's with me this morning, an indication, I think, of his commitment to this project. What we did was we developed a comprehensive integrated healthcare system that was targeted at the poorest of the poor in our community. But we transformed the way that we were providing care, the traditional model of access through an emergency room. We changed that to create access to a medical home with a primary care physician that became the gatekeeper for these individuals. The gatekeeper is the starting point in a network of healthcare providers. This network includes specialists, hospitals, home care providers, anything that the individual needs in the whole healthcare continuum. And the network functions as a unit. They are to provide whatever care is necessary for each one of the clients who are enrolled in a coordinated fashion, something entirely new for these clients. The program was designed to be user-friendly. One of the things that we did was we provided freedom of choice to the client to choose which one of 15 neighborhood-based clinics they wish to enroll and call their medical home. We also co-located not only health and human services in those 15 centers, but also mental health services. We provided a 24-hour access line for these folks to call. They can get information and also medical advice calling this number. And we gave each one of them an ID card, a healthcare ID card, probably very much like the insurance card you have in your wallet, that gives them instant access to healthcare. They can go into a pharmacy, get their pharmaceutical with that card. What we've done is so customer friendly that in the second year of our program, we reached over 62% of our target population, or over 24,000 people. I think it's pretty phenomenal. And the best part of this is that these people now have access to the mainstream of healthcare providers in our community. They receive state-of-the-art services in physicians' offices and hospitals that are recognized as among the best. The county has laid the groundwork for sustainable change in the development of delivery of indigent care. We've solved our local healthcare cost problem. We've reduced inappropriate use of the emergency room. We've reduced admissions, and we've decreased the average length of stay from over 10 days to less than 7 days for our clients. Word of this program has gotten out, and people are coming to look us over and find out what we're doing. It can be replicated with government taking a lead, but getting the buy-in of the key players in the community. And any
we
community...
have 1 minute to go.
And any community that does implement this program, everybody wins. The individual taxpayers and the community wins because they get a better value for their dollar. But most importantly, the client wins because they get better health care and better access, certainly. We all know this is a difficult problem to address. The state and feds have been attempting to address it. Hillsborough County does, in fact, have a working model.
You know, your problem is you lack enthusiasm for your program.
I've been told that before, sir.
We are now at the question period, and I'm going to call on Vin first, and then Jack.
I want you to explain just one thing you said to me, which is that you've gotten your cost problem under control, because the data you provided us shows that participation is increasing, your market penetration is increasing, but your cost per member is also increasing. And so explain that statement to me.
Well, we expected this question to come. I think the answer is that we had some difficulty in the first year of operation with our TPA, our third-party administrator. And so when you look at second-year data, you find that there is actually a combination of a lot of first-year data in that second-year data. As we're moving into the third year, if you start to look, our cost is going down on a per-member per-month basis. Michael, I don't know if you want to add anything to that.
I think that's true. The major problem we had in the beginning was that the TPA couldn't handle this job. They weren't set up for it, although they thought they were. So all the data is probably in the wrong time slot. And as we're getting into this year and are looking at the monthly performance, it's improving significantly.
I don't want to push too hard on that, but are we confident about that, or do we have preliminary indications that that might be the case?
We're confident in the operation. Our operating year starts February 1st, and the data this operating year is very much improved.
Has much of that reduction been accomplished by lack of specialist referrals or something, or shortening
the specialist referral was an issue and still is an issue. The county renegotiated the contracts starting February 1st and basically plugged some pretty large holes that the specialists could use. Those have been closed, and so we're seeing a major improvement in that area.
But I think the other point, too, is the reduction in admissions and average length of stay are making a significant financial difference.
Okay, thank you.
Jack?
Doctor, go ahead.
That goes very much to my question, and it may not be possible to answer, but have you, the total financial effect, has it been to slow down the mushrooming growth of the cost of health care, or has it, can you see some actual lid or total reduction by going to primary care?
I think when we started, we were looking at a growth curve very similar to everything that every other state and federal was looking at. Our intent was to change the shape of the curve in about the third or fourth year, in that primary care would take that long to have an impact. I think that we're comfortable that, in fact, is now starting to happen. We are seeing the effect of capping the amount of money available to the zones, where they function as a unit. And we've had a major learning experience this year, and the specialists learned that if they don't control their use of services, they don't get paid. And so the impact is starting to be felt through learning.
We have three questions in 2 minutes, first with Dot, Tom, and then Max.
You're working in a Florida legislative climate that's somewhat uncertain in this area, with legislation that was written to sunset in 3 years and the possibility of a special session this summer that will deal with some of these issues. How do you interpret this, the impact of that uncertainty or the climate on your program?
I think my best answer to that is that last year when the governor first released his Florida Health Security Plan, he had essentially ignored what we were doing. After several conversations with him, he changed his entire package to incorporate a section in his bill, and in fact it's in the federal waiver request for community health partnerships is what it's called in that particular legislation, so I think we're in pretty good shape.
Tom, and then Max. And I think that will conclude the session.
Many Medicaid-eligible people come to the clinics?
Well, that's the beauty of our clinics. We don't pay for the care for those individuals who are Medicaid eligible, but at every one of our clinics, one of the requirements to participate as a provider in the clinic networks is that they must treat every individual who comes to their door, whether they're Medicaid, Medicare, self-insured, self-pay, county eligible. I really don't know the number of Medicaid clients because we don't track the Medicaid clients, we track our clients only, but they are required to see anyone who comes to their door.
Do you have a program for vaccinating children too?
Vaccination of children is included in the plan. In our state, children up to 150% of poverty are generally covered by Medicaid, but if a child isn't Medicaid eligible, they come to our program, we can take care of the vaccinations.
Last question, Max.
Just briefly, one of the questions was dealing with the whole issue of families, and could you just expand briefly on the outreach and how people have the card, but how do they understand how to use this? What kind of educational process do you have?
Well, we weren't allowed to bring any visual aids with us. I wish we could have, because we have a package of information that we provide to every client who enrolls. The grapevine about this program is enormous in the community, in that people go out and tell other people about this program, and we get a lot of our folks coming in. But we provide them a lot of material. Because we are a very bilingual community, we have individuals in every one of the clinics who are bilingual and can speak, the language of the folks as they come in. We have